All right. Well, so now that we're actually being recorded, I'll summarize the last few minutes of what I was saying, which is I'm a rheumatologist by training. I've actually been in training for a little over 20 years as a rheumatologist. I've been at Johns Hopkins that entire time because I completed my fellowship there. And prior to the co-founding of the Myositis Center, for which I'm old enough to be a co-founder, along with Dr. Andy Mammon, who was the original co-founder and co-director with me, who is now doing this kind of work at the NIH. Since then, we've actually had two other neurologists join, as you know, Dr. Tom Lloyd, who moved on to take the job as the chief of neurology at Baylor, where he trained, which was an excellent opportunity. And so that gives us opportunity to collaborate, spread our wings, and continue to do this work now in a more collaborative network. So there are good and bad things about people moving on, but I think in general, that's actually a very positive thing for everyone, and certainly including Tom. Payam Mohassel is now our co-director, and it's always been a rheumatologist. We actually have two of us in rheumatology, Dr. Julie Peck and I. Julie spends a little more time in the clinical trial space, myself, and then in the rheum space, and then in the neuro space is a neurologist as the co-director. So before we developed the Myositis Center, nobody really actually claimed this disease. Neurologists tended to diagnose it, but because I'm sure you're all aware, although I want to challenge that notion, there's technically said to be no treatment, beyond exercising and maybe creatine. There may or may not be therapeutic options. Thankfully, we do have a few clinical trials, which are exciting, and I'm hopeful. I'm always hopeful. But I think because it didn't have any real therapeutics that were labeled, meaning the FDA was approving them, patients would be told they had the disease and then they just nowhere to go. And then when we developed or founded the center, we then had a home, I think, for IBM in which they saw a neurologist or a rheumatologist. And I think the beauty, and if we have time, I'll show you just a sneak peek of this data. Nobody has actually seen this data really, so I'd like you to keep it to yourselves. Maybe I shouldn't show. Maybe I should talk about it because it's being recorded. Because some of this data actually will probably use to ask for further funding.
Whatever your desires are, we will accommodate you.
I will just tell you a little about it, but I think it's important to say that I think IBM is likely not just one disease. It's a conglomerate of diseases. I suspect that they all look similar, but some may be treatable earlier, some may not. And so we can talk a little bit about that. Suffice it to say that I think IBM has had a difficult time kind of finding a home and who treats it, who doesn't. Many patients come to me and they say, do I see you again after once? Because I was told I don't see a doctor. And what we've determined, we've been collecting the IBM functional rating scale, the IBM FRS, and I'll stop in a moment and ask you, have your questions, but I'll just give you this final intro. And what we've noticed is in collecting this data over time, you all are telling us something about this disease that I don't think we could see without longitudinal data. So I do think it's important. We were talking offline right before the meeting started that it's very frustrating, also very frustrating for a doctor or intimidating when you all come in with much more knowledge and when you can speak about pathological correlates under the microscope and the biopsy, and doctors who hardly see IBM are a little intimidated. It can become a little rough. The other thing that happens is that patients are told, well, there's really not a lot I can do. Good luck, kind of thing. It's hard from the doctor's standpoint as well. We want to be able to give you a therapeutic option. We want to give you a medicine. We want to stop it. We want to cure it. And because we can't, it becomes very frustrating on both parties. So I will stop there just to say that's my story. That's what we do. Those of you who've had the pleasure of being at our center, welcome again. Some of you took the excursion, I believe, at our center at the TMA meeting recently held in Baltimore, where I am a very proud Baltimore City resident. And I really feel like we are really making some strides. Slow. IBM progresses for the most part, except for some, relatively slow. So it takes a long time to see progress. And I know how frustrating it is for all of you on this screen that all you want is progress and all you have is time. So do know that there's a lot of people in your corner. I'll stop there. And, Mr. Cressman or anybody else, please let me know how I can help and what questions I can answer.
One of the dilemmas that we face as veterans, as I shared with you earlier, is the fact that the Veterans Administration does not recognize inclusion body myositis as a disease that's even existing. And because of that, when a veteran applies for disability benefits, they are they are assigned to do what they refer to as a C&P exam, a compensation and pension exam. And this goes to a contracted medical examiner, typically a nurse practitioner or a physician's assistant, that will examine us. And I don't think I need to impress upon you that their familiarity with inclusion body myositis is almost non-existent.
Correct.
And as such, they try to pull rabbits out of hats to find a disease that they feel, they meaning the VA, is the closest or most similar to IBM. And we have had veterans here that have been examined for an IBM claim for arthritis, fibromyalgia, sleep apnea, and it has just been a very, very long list of exams that have nothing to do with IBM, and it's very, very difficult for the veterans to get that. So our first goal is to get the VA to recognize the disease. And in my research, what I've looked at is that they've got a manual, as you might assume. The government has manuals on everything and everything. But according to your information, Dr. Christopher-Stine, when was IBM first discovered, so to speak? How long ago did that occur?
Yeah, probably close, a little over 50. I mean, well, it's debated. I think that Griggs was probably the first person to bring it to the forefront. I think this is debatable, but I would say that it was recognized in medicine for most, well, not most physicians. Physicians who knew would know in the 1970s. I'm sure you've probably seen things much earlier than that, but I would say that conclusively, the 70s were probably the very first intro where it seems like the same disease phenotype, like clinical correlates, were in the literature enough to be recognized as a unique disease. Now, having said that, where it comes to the forefront or where we start seeing this come about, I never heard about it in medical school, and I went to medical school in the mid-90s. So having said that, being described and coming into the purview of any person, I trained in internal medicine, I never heard about it until 2002. So I'll be clear, there's a huge lapse. At least that's my experience. And I have, some of the now expertise in muscle disease. I think it's a little different now, and it's permeating to the medical school curriculum a bit, but I never heard of it for, almost whatever was, what is that, 30 plus years afterwards.
That is amazing. And the reason that I asked that question as to when it was discovered was the fact that the manuals that the VA had developed to list all of the diseases that were known and conditions and diseases, so on and so on, was published in the 1960s. Mm-hmm. So as a result, guess who got left out?
Yeah, and, of course.
And that has been one of the driving aggravations that the veterans applying for disability benefits have faced. That it doesn't exist, and that's our first step, is to get it to have them recognize this.
So may I interrupt? Forgive my ignorance. I think this is a give and take for me to understand. So I know nothing about this. So is it true that there have been no updates for any disease state in this manual since the 60s? Is this true?
I believe there have been updates on a rather irregular periodic basis, but the only mention of any kind of reference to myositis is just the generic term myositis, and they group all into one. So it is not not unusual for an IBM veteran to be required to take an examination for polymyositis, and they check the joints. It's so frustrating. I received my disability benefits, and I will have you know, this is going to be news to you, I'm sure, that this little finger is 10% disabled because of inclusion body myositis. They went every single joint had its own disability rating.
Oh my goodness gracious. Oh.
That's what we've been facing.
Yeah, we can do better. I think we can do better.
Indeed. So now with that, we'll again, your questions are welcome, and please keep them generic and in a broader scope that can benefit all of us rather than your own individual situations. With that said, if you would be kind enough to raise your hand when you have a question by lowering your mouse down or your cursor down to the bottom of the screen, and use the reactions icon down there, and there's one that says raise hand, and that will show you up in the upper left-hand corner of my screen, and that way I'll know you're wanting to ask a question, and I won't lose you in the Bermuda Triangle. And with that said, Chip Thomason, good morning. Welcome.
Good morning, but it's Lisa Thomason, Chip's wife. And one of the questions I have, which is one of my frustrations, Chip is newly diagnosed with IBM after 3.5 years of broken medical system. And like you said, he has been, he's getting physical therapy and occupational therapy, but he's been told basically to go home and live with it. But what you're saying is there is some treatment or, experimental stuff, and the neurologist isn't going to see him again until a year from now. So what exactly is some options that are generic, that I'm not asking you to do anything related to my husband, but when you talk about there are some options, what are those, if you don't mind answering?
Yeah, no problem. So welcome, Lisa. I'm sure it's so frustrating. It's not, so your husband's story is not an uncommon one. Actually, 3 years is pretty good, but if the symptoms predated that by many years, that's more the story. So it's, the symptoms start 10 years before, 8 years before someone comes to medical attention. And then it's 2 to 3 to 5 years before they get to the right person to finally understand this. So I do think there's a lot of education to be done at the primary care level, because that's the gatekeeper. You can't get to us if someone doesn't tell you what's going on. So I'll speak to that for sure. Actually, and I'll answer your question in a moment, but I will say as a side note, those of you who know that Peter Frampton has been very publicly vocal about this. I met somebody recently, this happens all the time, where they say I was diagnosed by Peter Frampton on the CBS morning show. He was talking about his symptoms. I'm like, wait, I have that. So kind of nuts. That's not uncommon. So if you need to be diagnosed by somebody talking about the disease, that's helpful, and awareness is important, but clearly we can do better in the medical establishment. So that's point one. I'm really sorry that's been your experience, and I don't think it's uncommon, but I do think we're all trying to do much better. There are 2 current trials that are going on. They are, as far as I know, at least one is fully recruited for sure, and that's the Abcuro ABC008 trial. It also has another name that I'm not going to, it starts with a U, that I'm not going to try to pronounce, because I'll mispronounce. But ABC008 is a very specific marker on T cells that's looking at these killer T cells, cytotoxic T cells, or T cells, lymphocytes. And that is closed, but that is a targeted therapy that hopefully in a bit of time, it's going to take a while, because I told you the disease is slower. So in order to see something that's different in a placebo group versus a treatment group, it takes over 70 weeks to do that. So unless there's breakthrough status or something that goes faster to the FDA, it's going to take a little while if that is approved. But maybe that will be our first on-label therapy. I do not know. We're participating in that trial, as are many of our friends and colleagues that do this kind of work. So while it's not available to your husband today, the hope is that if this or other therapies that are coming into trial are trialed and then the FDA is labeled, then there will be something. In today's day, there's also sirolimus. I don't know, it's potato. And that's an immune suppressant. And that affects what's called autophagy. It's sort of a cellular process that happens at the muscle, at the muscle cell level. That is also recruiting worldwide. I believe it's near recruitment, But there is, and I always recommend the Myositis Association's website to tell you what's still recruiting. Those are the only two current trials that I'm aware of. I think it's near filled. It's filled at our site. I just tried to recruit somebody in last week and it was filled. So these two drugs, if we're successful, we haven't been successful in the past with other therapeutic trials that I've been very excited about, and they fail for many reasons. We're getting better. So hopefully that is on label. When I say about maybe there's a treatment version of myositis, interestingly, I've spoken to the women's group in IBM, and this is not this group for the most part. There are women service people I recognize. I know the large majority of veterans will likely in this group be men, and more men get this disease. So one thing that of interest is that we don't know whether it is autoimmune or neurodegenerative or both. There's a vehement argument. Oh, we just don't know. So we know there's both processes. It certainly looks inflammatory, but no inflammatory, anti-inflammatories seem to help, or immune suppressants. It certainly looks neurodegenerative. I'm becoming more and more of the thinking that maybe it's both. And there's an inflammatory phase, and then there's a neurodegenerative phase. And again, this is my own thinking. This is not necessarily yet substantiated by science. And maybe there's either a treatment group where somebody would be receptive to treatment, or if we can come to you early enough, when you are early in your disease, you might be more amenable to therapy. So those two things sit in my brain to think about, well, if we could identify the right people that would be amenable to immune suppressants, maybe there's a subset. I'm saying a lot at once, and I'm happy to stop and clarify. The final thing I'll say, and I've now seen this 3 times in just the last few months, is that patients that were labeled IBM might have what is called PM Mito. I don't even believe polymyositis is a disease. I honestly don't. I think it's a precursor to IBM or a misdiagnosis of something else. But I will say that there are people that look like they have a crossover. And this is a histologic, a tissue diagnosis. And you need a good pathologist who knows, a neuromuscular pathologist, preferably, who knows the difference, who can see the features on biopsy that suggest something called PM Mito. The reason I bring that up, many neurologists will say, look, that's just early IBM. And it might be, it really might be. And you may just not be able to do something. But I do have a small subset, just empirically, what I have treated with various things, methotrexate, IVIG. IVIG has not worked for traditional IBM in our studies either. So I'm not saying that everybody should go do this at all. However, this very small subset, which might be an overlap or might be a little different or might be earlier, may be amenable to therapy. Because you said your husband had 3 years of trying to find a doctor. Now, if he's actually started tripping and falling 10 years ago, that's not new IBM. So I am trying to find those people who get to diagnosis earlier and or may have these very specific features on their biopsy. So maybe not all IBM is IBM. I'm pretty sure that AI and other technology is going to tell me and others, if we have enough biopsies under a microscope, enough stories, enough data, I bet we will know who is going to be more treatable initially. That doesn't say that, like, this doesn't sound good for people that go down a large slope and get sick faster. I realize there's still an unmet need there. But for today's day, what I'm looking for is who can we maybe treat? Because what happens is the vast majority are not in that category. And then those people get stuck and labeled in that same category and are not offered therapy. So anyway, long answer to your question. I think it's important for many people on this screen to think about, if you're early in your disease, it might be worth a conversation to say maybe a small dose of immunosuppression plus IVIG. And I will do this for only two IVIG sessions, 2 months. If I don't see any improvement, and it's objective improvement, I'm going to measure dynamometry, which is quantitative strength measuring. I'm going to measure your strength. I'm going to ask you your IBM FRS, which doesn't change as quickly by any means, but your strength does. I want to see, is there a functional difference? Otherwise, I'm not going to leave you on a medicine for months and months and months. IVIG, I give only 2 months and recheck. And in the recent past, I've had 3 responders to the point where they're strong enough that they don't use their assistive devices like they did and such. So I don't want to provide false hope. I do think the vast majority of IBM patients with IBM have not responded to therapy. And I've been the one to say, look, I think you should get off your therapy. This isn't going to work. I want to be clear about that. But that little sort of needle in the haystack, or trying to be a little better about not labeling everybody in one big lump, calling everybody IBM and it's the same thing, I think we need to more finely phenotype, meaning, can we see different groups that might have reception to therapy? Last thing I'll tell you is that we are thinking a little bit more about maybe these cocktails, not the ones that are at your bar, but the ones that maybe put back certain amino acids, certain metabolites. We believe that maybe we might have the ability to do precision medicine, that you will come into us one day. This is my dream. And I say, aha, look, here's where you're metabolically unsound. It sounds like, you go to, not right now, it sounds like some of these doctors that I don't know are really doctors that offer you everything, including stem cell transplants, which for the most part have not really shown a benefit. But I want to make it such that we do the science in the way that is rigorous, is repeatable, and then maybe in the future there will be a cocktail. There'll be something that we can give back saying, look, it looks like you're low on glutathione or X or Y. So those are the dreams I have for the way we should treat this disease in the future. So the question is, what can he do today? Make sure he doesn't have PM mito. Ask them to make sure the biopsy was read by a neuromuscular pathologist to make sure that's PM MITO, stands for mitochondria. It has mitochondrial specific mitochondrial features on the biopsy that somebody that's in the know will know, because those people probably deserve, at least in my opinion, a small trial of immunomodulation or immunotherapy. And also make sure you're doing the right exercises, even though exercise sounds like that's not a prescription. I've said this before, Tae Chung, and you may know this name. He's a PM, physical medicine rehabilitation specialist at our hospital. And a long time ago, one of the patients wasn't doing exercise. He's like, you've got to make them, impress upon them how important it is to do the right exercises for the disease. And I was like, yeah, it's exercise. And he said, would you have a patient who has rheumatoid arthritis not take their methotrexate, the medicine that you prescribed? I was like, well, of course not. And he said, well, that's the prescription. So I also have seen exercise in the right hands absolutely help maintain the disease and not have the strong trajectory downward. So making sure the physical therapists and occupational therapists who see you, and again, I realize this is also a problem. Everybody says, well, I'm in Iowa and I don't have a physical therapist here. I can't have the benefit of the Hopkins Myositis Center. We're trying to do better that way as well, educating more and more people. Our dream, my dream, would be to have a physical and occupational therapy network. We can do this and teach people so that people get the right not only get the diagnosis earlier, but get the right exercises earlier to maintain this so that you have a much smaller or no strong decline. Anyway, I promise that answer to all the questions won't be that long, but there was a lot in there, and I wanted to make sure I touched on all those points.
Well, thank you for that. According to the biopsy, but I will double check what you said to make sure that it was read properly. Yes, 5 to 6 years in. So we are relatively early, but
you are.
Thank you very much. That was what I really needed to hear.
There is another thing. I do not work for this company. I do know the person that does this. And the other thing that you might, if it's not bank breaking, and it's not free, it's about a $500 investment. And then the monthly video investment, some of you may have tried it. Some of you may have responded, some not. I think it's worthwhile, at least today. I have not seen that. I've seen enough empirical data that says that somebody that can exercise who's early on in the disease, something called blood flow restriction, BFR, I think it's worthwhile at least looking into. The company that I'm most familiar with is SomaVive. It's SOMAVIVE.com. I'm not getting kickback. I have nothing to do with the company, but I do feel like I've been referring more of my patients because I've seen some suggestion and patients themselves feel better sometimes. So again, it's not free. It might be cost prohibitive, but if it is not for you, something to consider while we try to get better therapeutic options. If you can maintain where you are, or at least not drop off the curve so quickly, even if that's not the cure or the medicine for the disease, it at least buys me some time so that when something is approved, you'll be in a better state to take advantage of it. Thank you.
Thank you very much. And next up, there's John and Teresa. Good morning. How are you?
Good morning. Thank you. Good morning. Thank you, doctor, for being with us. I have two quick questions, please. The first is, you mentioned at the beginning of your presentation, neurologist versus rheumatologist. Could you please clarify for us what each specialty is focusing on as it relates to myositis? John has IBM.
Yes,
We do see Dr. Abeda, a rheumatologist up at your place. And
one of
then
my favorites. She's a great doctor.
the second question we have is, could you comment on mitochondrial cocktails as having any value? Thank you.
Yeah. Great. I feel like I planted you, Teresa, that you could, I really could not have asked for a better question. And had I shown you my slides, they were actually, this is some of the things that we actually talk about. So let me tell you about rheumatologists and neurologists. I once wrote an editorial called Neurologists Are from Mars, Rheumatologists Are from Venus, because we sit together and I'm like, wait a minute, are we even like, we're in the solar system? Are we on the same planet? And the reason that is that we really thought of myositis very differently. But I will say, as the field has evolved, I think our center and others that have been multidisciplinary have taught each other. So if the Hopkins model is probably very similar. At Mayo, Pittsburgh, places that have center-driven care, we're in the same space. We largely overlap a lot. What do neurologists do in myositis? So outside of IBM, just myositis in general, they usually do the electrical testing. So that's the EMG and nerve conduction velocity testing. They tend to do the muscle biopsy. Sometimes neurosurgery does this. Sometimes general surgery does the biopsy. Sometimes it is a person who's trained. So a neurologist who has an extra year of training in neuromuscular medicine, those are the people that do that see myositis patients. Traditionally, they diagnosed you and they're like, good luck, go on your way and find somebody to treat you. And that was us, the rheumatologist. And so now neurologists also know how to use immune suppressants to treat. And I mean, many of them did before, but I think a lot of them were not trained that way. So there's a lot of crosstalk now, and I think that the lines are blurred. Rheumatologists in general have much more training in using systemic therapies that suppress the immune system. Certainly neurologists do as well, right? Anybody that specializes in multiple sclerosis who's a neurologist knows full well how to use immune suppression. And some of the other neurologic diseases require immunosuppression. But so I think that's really, and that's a long answer, but they do a lot of the diagnostic testing, and rheumatologists generally tend to do a lot of the treatment. In IBM, there's not as many of these treatments or any traditional treatments to suppress the immune system, so it's a little more blur. Dr. Albeda is in rheumatology and has specialty in musculoskeletal ultrasound. So the other thing that rheumatologists, sometimes neurologists do this too, is do ultrasound testing of the muscles to really try to figure out which muscles are affected. And it's a less intrusive way to take a look at the muscle architecture outside of MRI. So that's really how we think about it. I think like I said, in a specialty center, they blend and we both see IBM, but I would say in the community, I would guess that inclusion body myositis is likely more shunted towards neurologists from the primary care office because they don't have the other features that a rheumatologist sees. So what is a rheumatologist? I feel like I need a plaque to try to explain this to like even my own family. It's a doctor of what we call connective tissue diseases, so joints, bones, muscles, and the tissue between all of them. As a rheumatologist, I take care of rashes, joints, lung disease, muscle disease, and IBM tends not to have those features. So because there's no overlap beyond not an inflammatory arthritis, many people I'm sure like myself have osteoarthritis, degenerative arthritis, but an inflammatory arthritis, a rash, lung disease, that's usually not part of IBM. So they would more likely shunt over into neurology because there were not other features of the disease that would require a rheumatologist specialty opinion. Hope that helps. And mitochondrial cocktail. There is a mitochondrial cocktail. We actually give this sometimes in our checkout information. I have to say, like I usually say, look, the only thing that's probably going to hurt is your wallet. It doesn't hurt much to try it. I don't think we have good evidence that it works. And that is just giving back vitamins and minerals and, things that try to affect the mitochondria non-specifically. However, what I spoke to, to the last question that was asked of me is maybe there will be these mitochondrial cocktails, but quite precision medicine prescribed. So in the future, we might see a mitochondrial signature, a metabolic signature of certain supplements that really will actually supplement the patient, but on a much more individualized basis than just saying, take alpha lipoic acid or cocktail X or B. The only other thing that might be helpful, it's not a mitochondrial cocktail, but some patients find that creatine is helpful. Creatine is the building block for muscle strength. There's been some data out of Sweden that suggests it might have a minor, it might help. I find that sometimes it's a little intolerable with GI side effects for some people. But again, if it's tolerable, I literally send people to like GNC or a nutrition store and say, just go get some creatine and take it the way that it's prescribed. The way that it was prescribed originally, I believe in the original data was at 3 grams a day. There was a load of, I want to say 8 grams and then 3 grams daily. But I don't want to give you that prescription of 3 grams if the type of creatine you're taking isn't meant to be taken that way. I would take it according to the instructions on the powder or the bottle that the package that you're given. So that's the answer to that. I hope that's comprehensive for you. Yeah, and you have somebody who's very interested in, and we can talk a little bit more about that, like palliative care. Palliative care is not hospice. Palliative care is like taking care of a long-term disease well. And Dr. Albeida has specific interest and expertise in that. I really do think that we really learn well together. But rheumatology, neurology, that's how we're trained. That's why IBM may come to neurologists a little bit more. But in a specialty center, we cross-train and we both see the patients. And you don't have to see both. You don't have to see both.
Thank you.
Sure. Who was next? I see lots of hands.
Kevin Donahue's next, and Jim Cressman just lost his internet. So
is that what happened? I saw him disappear. Okay,
yeah,
well, glad you're co-host.
He's out in the mountains right now.
Okay.
So Kevin,
well, lucky we got you.
Kevin Donahue, there you go.
Yes. Good morning, Dr. Stein. It's a real honor to have you with us today.
Thank you. Nice to see you.
I'm a patient of Dr. Meckley up at Johns Hopkins. I've been seeing Dr. Meckley since 2018.
Yes.
And my question is, what is the promise of pioglitazone?
Great question. Yep.
There's a lot of conversation about pioglitazone and whether or not it could help a patient like me with IBM.
Sure.
So that's my question. Yes.
Great question. So pioglitazone is a medicine that's traditionally been used for diabetes care, so type 2 diabetes. One of our younger associates years ago in rheumatology named Britt Adler, who was actually in the Myositis Center, but has now gone on to take care of patients with POTS, a different disease. It's a very sort of debilitating disease. She had the notion that something called PGC1 alpha, which is again, let me just be clear, I'm not a pioglitazone expert, but it is the molecular the target of that medicine, that it would also cross over to some of the pathology that is present in an IBM. What we did, well, we being Dr. Albeida and Dr. Adler led that study. They did pre and post needle biopsies in the quadricep muscle in patients who were taking pioglitazone. They gave it to them and then they studied them off and on the medication. And what we saw is, yes, there's a signal there. We don't think that one person really seemed to respond, but really the general signal, I think, and this will be published soon, so I don't want to speak too much out of this. I saw the 10th iteration, I think, of that manuscript where people are looking carefully at it before it's submitted. And I do think that once it's submitted, we'll walk through the findings with you. Suffice it to say that we saw a signal, I think, enough that it makes us wonder whether this might be a targeted pathway, but whether it might make sense to have a medication that is more targeted toward PGC1 alpha than pioglitazone is. So I think it's probably right target, wrong med. So I think it gives maybe early indication that might be a mechanism to consider maybe for others. But would I take pioglitazone if I were you? I can't say that we can offer that. That is a question we're going to be asked when this comes to, I'm sure, what's going to be happening is this going to come to this kind of meeting and people will say, should I take it? And I think that the conclusion probably that I can say is there's not enough evidence to recommend that it's going to be a potent enough therapeutic medicine for you. Taking something off label always has its own adverse effects, so I can't necessarily recommend that because then what are the downstream effects that we don't expect? But I do think that pioglitazone was a teacher for us that likely said, probably need to look closer here. It was a positive signal, but just maybe not enough at that, using that medication for a different indication. Perhaps we need to actually develop an IBM specific targeted medication that's looking at that pathway. That's the best I could say right now, but my goodness, I really could not have planted better questions in this audience. You're also knowledgeable and ask wonderful questions. Hope that answers your questions. And again, you have an amazing doctor. I trained every one of these doctors that you see because I physically can't clone myself and see everybody, but the closest thing I could do is train excellent physicians whom I would see myself as a patient. So I hope you feel the same.
I do feel the same. It's a wonderful entity up there at Johns Hopkins. I always look forward to going up there. And also too, I also go to the physical, occupational, and speech therapy.
They're
And I
amazing.
normally see them all at the same time. They're a game changer, and they have maintained my quality of life to the point where I am a very productive citizen. And not only that, I am coaching a hockey team full time. So I am in the game thanks to Johns
Oh,
Hopkins.
I might have to quote you on our website. I love that I'm in the game thanks to us. Thanks so much. That makes me thrilled. And it just really reminds me that exercise is so important. I once saw a patient that did, go through the program with our physical therapist, occupational therapist. I examined their strength and I do it quantitatively as well. And I thought I must have got the wrong measurements. It's impossible. I've never seen anybody get stronger with IBM, let alone like really maintain well. And I thought, wow, that was years ago. And it was my first thought that if this were an FDA medication, it would get approved. So I always think of exercise that way. And my exercise colleagues remind me of it. And our exercise team, our whole physical medicine, rehabilitation, PT, occupational therapy, and speech at Hopkins just make me look good because honestly, really, they're doing the hard work for all of you. So I think people say, oh, is there just exercise? That sounds so, undramatic. Well, A, it has virtually no side effects. If anything, it's going to keep you younger longer. And B, it really works when it works. So I'm so glad that you're a proponent of that team, that you say that. And I just think we need to do better trying to educate more physical and occupational therapists to try to transfer that knowledge globally and certainly nationally in the US to really teach other therapists to be able to get the kind of results that you have. I love that you're still in the game. That makes my day. Thank you so much.
And not only that, Dr. Stein, my wife, my caregiver, I am 100% reliant on caregiver support. She has been trained to execute these exercises. I have my own therapy room. So I do this religiously, and it is really making a big difference, keeping me in the game and productive to the point where I have dedicated myself to work another 10 to 15 years in my occupation on the job. So that is a big deal, and I wanted to share that with the group. Over.
Love that. I also love your mindset, and it's not always easy, right? Like I don't think we're allowed to be upset. We're allowed to be grieving. We're allowed to be sad. Like I don't say that toxic positivity is the way I teach my patients to live, but man, people who could somehow see that glass half full rather than half empty, that in itself is therapeutic. If I could study the effect of positive thinkers, I can guarantee you they do better. So seeing the future, staying in it, not being unrealistic, right? We're all realism. I don't think we don't need, to sugarcoat a really hard disease, but let's try to see like that we can be the best version of ourselves. And when you can harness that and really truly believe it and internalize it, I actually think it has therapeutic benefits. I truly do. So thanks for being such a great proponent of that as well. Really, congratulations to you. So it's wonderful to hear. Really nice to meet you, Mr. Donahue.
Thanks, Kevin. Next up is Ricky Marks. Doctor, you may know Ricky Marks. He's on the board of TMA. Ricky?
Yes.
Very good. Hi, Dr. Stein. How are you?
Good, good. I have to tell you all, I go by Dr. Christopher. It's okay. I mean, I love my husband, but I've been Christopher-Stine for years to just honor the fact that I do have a wonderful, loving husband. My name is so long that people don't know what to call me, so they end up calling me just Dr. Lisa. But it's actually, so if you hear it, I go by Dr. Christopher. I should have said it at the beginning of the hour. So Dr. Christopher, if it's okay with you.
That's fine. That's fine.
Thank you.
Well, Dr. Christopher, just doing your presentation, it brought up a couple of thoughts. Let me just first say that I am a big proponent of exercise, and I'm fortunate enough to work with a lot of the medical students, or from, not medical students, but physical therapy students from Emory.
Ah.
And so I'm actually their go-to person, their experiment in IBM. So
Wow.
trying to get the word out that way, but it just brings to mind when you say the right exercises. I've been focusing heavily lately on my hands and
Yes.
making sure that I'm doing something with my hands every day. So the question is, where do I find information on quote unquote the right exercises? And if there's someplace I can go or someone there at Johns Hopkins that you referred me to, I'd appreciate that. And then secondly, in your presentation, you talked about no involvement with the lungs, but I've been on several of these conferences, and we talk a lot about the accumulation of mucus and the lower cough reflex that we experience. So is there some type of association with IBM and this production of mucus and decreased cough reflex? Those are my questions.
Again, gosh, I really I mean, you couldn't ask better questions. So I'm going to take the second one first, and then you have to remind me if I get the right one, the right exercise, right? Let's take the mucus question first. So thank you so much, Mr. Mark. I would say this, you're not the first person to tell me this. When I say no involvement in the lungs, the traditional way that myositis affects the lungs is something called interstitial lung disease, which is an inflammatory process in the lung itself that prevents the proper oxygen exchange between the blood vessels and the air sacs in the lung. So that type of lung disease is not present in IBM as far as I've ever seen. I haven't seen interstitial lung disease. I'm not certain, and I'm not a pulmonologist, but my conjecture of what you're describing, which others have described, is probably muscular. So it's an inability to clear from a muscular standpoint a vigorous enough cough reflex. So why some people develop that and others don't, I don't know. So I think insofar as it's like a downstream effect of a muscular problem rather than a primary pulmonary issue. That's what I think. Whether it might be that you actually accumulate more mucus, I don't know. And I always learn from patients, so I'll catalog that here and think about that a little more with our pulmonologists, who are also part of our center, and ask if they have some thoughts on that. I have always attributed it to the fact that I thought that it was a decreased cough reflex and just can't clear, because we're always clearing mucus out of our pulmonary system every day. It's in our mouths, our pulmonary system, even deeper down, for sure in the bronchi. So I think maybe that, but always willing to learn and think about this a little more. Maybe there is something, but it's not the typical lung findings in polymyositis, dermatomyositis, or the antisynthetase syndrome, these other types of myositis where we see this lung involvement. The right exercise is a hard answer. There's a couple things that make exercise right in IBM. It's isometric. So using your own body weight as the weights. People should not, in my experience or in my training, lift heavy weights. So let me be clear. We are not trained as doctors at all very well on nutrition or exercise. Yes, we get told about it. I had 4 hours in nutrition training and 4 years of medical school, and I don't think I can recall being taught about exercise. So we are trained so different than PT, OT. They've trained me. I've understood it through their eyes. So I want to be clear that I don't speak with expertise at all in this regard. But the right exercise is isometric. So making sure you're using your own body weight to the extent that you can against itself. Doing individual finger flexor exercises and not just hand grip, because you can grip, but you have individual flexors that your fingers become weak if they're involved, and they're usually involved in this disease. And that's one of the most debilitating parts of the disease, because it's difficult to do ADLs, your activities of daily living. So making sure you're doing pegboard and certain exercises. The right exercises per se are on the TMA website. So Dr. Helene Alexandersson from Sweden has done a whole suite of these to kind of just give you an example, and she shows you how to do them. She was the first person in this world, the sort of myositis, to get people off the couch, because we were taught initially, don't move. I think even someone said it in the chat, you're going to hurt yourself. Your muscles can't take this kind of exercise. And people have burnt out muscles. I get it. Like they don't move if they don't move, but other muscles can. And what happens once your quote unquote burnout of certain muscles happen, you then compensatorily use other muscles, which is good, until you're straining those muscles, which is bad. So the right exercises do exist sort of on the TMA website. But then, Mr. Marks, I would like to tell you that it is an individualized story, because I think we can give a generalized overview like the one that is there for you to see and teach yourself and teach your own physical therapist. It sounds like you are the teacher. But then actually it's tailored to the individual. So Finn and Ruben and my team over at Johns Hopkins always reminds me that it's not prescriptive, like everybody gets the same thing. They need to sort of take a look. So, and where that comes in, that individual specialization, that's in the expertise of a well-trained physiotherapist or occupational therapist, which I can't speak to. So there is sort of a global way of exercising safely and helpful, in a helpful manner. And then there's the tweaking, the fine mapping of your exercise program. And that really does take a trained therapist that understands how the disease is affecting your muscle and can tailor your therapeutic plan to those that muscle involvement pattern. I hope that helps.
Okay. Well, Dr. Christopher, just in closing, I think I go through a series of exercises each day, ranging from throat exercises to swallowing exercises to Kegel movements to isolation of individual muscles. Because I use a sit-to-stand lift, I have to make sure that my lats are strong and that my traps and my deltoids are strong, because those muscles are still very active. But the ones that I have problems with will definitely be the legs. So if I get my legs stretched or or at least get the quads stretched out, I'm pretty happy. So it kind of rotates on a weekly basis. And right now, I'm actually into the chair yoga. That was something that was interesting, that was just introduced at the recent APC to me. So
Yes.
every day I'm doing something, and it's a little different each and every day. But I want to make sure I'll go back and check on the TMA site with Dr. Anderson and see what she's offering, and make sure that I'm, as you say, teaching properly.
Yes.
Thank you.
Yeah. I think it sounds like you're a great teacher. I think the other thing you mentioned is consistent daily exercise, which, look, I'm on the screen telling you to do that. And do I do it? I sure don't. And I should. So I definitely think, like, I should say as I do as I say, or maybe not as I do. And truthfully, for IBM, I mean, I'll be honest, right here, right as my public confession, when I exercise, I feel better. And for IBM, I think exercise is life. Like, you have to do it consistently every day, something. And a lot of times I'll interview patients, and it's usually the spouse that's telling on the patient, like, are you exercising? They're like, no, he's not, or no, she's not. And then they get in a fight because one is telling them to exercise, the other saying, stop nagging me. But I think you either need a nagging partner, nagging spouse, or just an internal monologue where you really have really good, a good sense of yourself, and really a lot of motivation to keep doing that every day. That by far, daily consistent exercise has shown, in my own experience, I would tell you empirically, the people that do that do better. They just do. They do better than those who don't. So I love that you're doing it consistently and rotating. Again, I don't have enough expertise to tell you how to rotate it, what to do, and that you remind me and bring up that speech and swallow, the speech and swallow folks that do a lot of the work with those of you who have dysphagia or swallowing difficulty with this disease. That cannot be underestimated, because obviously one of the risks of the disease is choking. So they teach you how to swallow properly, what to do and not to do. I cannot underestimate the value of our speech therapy program where I practice, and I think it's huge to get a formal evaluation if you have had any notice of even mild issues with regard to swallow. Yep, thanks for bringing all that up. Great question, and I love that you're doing it. This is wonderful. Good for you.
Thank you.
Yeah, very nice to meet you.
Dr. Christopher, Jim is back from the Olympic Training Center. That's where he was at.
Yeah, I was trying out for the Mr. Universe contest.
Wonderful.
Yeah, I apologize. Technology reared its ugly head, and I didn't have a 12-year-old close by, so I had to fight with this myself. Suds, thanks for taking over. Mr. Hernandez, good morning. Unmute yourself, please, and welcome.
Oh, I think you're muted.
Yeah, you're muted. If you could unmute yourself there. There we go.
I just realized that, okay, I don't have a 12-year-old here either.
They're rare. They're hard to find now at our age.
Oh God, you gotta see the negotiations I do. I got 4 grandsons, 3 of them in college.
Wow.
Anyway, to Dr. Stein or Dr. Christopher, whichever it may be, my last meeting at the Johns Hopkins was with Thomas Lloyd before he left you. He examined my biopsy, and the biopsy is sitting currently at the NIH with Dr. Yago Fernandez.
Aha.
Fernel.
Yes. Yes.
They got me there in the event I may accommodate or I may be qualified for some kind of study when and if it ever happens.
Okay.
I have seen them several times also. My question is to expand on what Mr. Marks and you were discussing just now. Recently, I was diagnosed with that coughing you're talking about. I went to a pulmonary doctor who put me on, and today's my last day of my last 30th day of Brio, which seemed to work because it took the wheezing out of my chest and it let me sleep through the night without coughing my brains out. Sadly, the VA does not recognize the Brio as a medication that they cover, which is very, very expensive. And I have a pulmonary exam with the VA on the 14th of November. But in the interim, I found a sympathetic ear there who sent me a prescription of Wixella. Wixella, W-I-X. I think it's in the same category as Brio, but it is covered by the VA. So it kind of reduces my cost, making it more affordable. The Brio was over $400 a month, which was
wow.
It was really out of my range. So anyway, to expand on the coughing part of it about the pulmonary, I had to be a test on that. Yes, I had a problem for several months, didn't know what it was. Finally, my rheumatologist, who was examining me, said, "You better go to a pulmonologist because you've got a bad wheeze in your chest." That was several months ago. This past month, I just finished this morning. I finished my 30th day. I believe they give you a capsule that has 30 inhalers on that Brio. This morning was my last day, so I'm starting on the Wixella, which is twice a day as opposed to once a day.
Okay.
So I don't know if that helps you or not, but I'm one of those patients that Mr. Marks was talking about with the coughing.
Yeah, I'll take it to heart. I think this is true. I think when I get into a group that's large and really where you are in the same space and people nod their heads and say, "Oh yeah, that's a thing." We've seen it before, actually, in a different way with in a different group where women and others were reporting pelvic floor problems or incontinence. These are things that we would never have asked about. And I really feel like now that you're saying this, I've actually heard this enough that maybe we should make sure that there's not a secondary lung issue that we've attributed only to failure to clear secretion. So thanks for adding your experience to this. And I looked it up because I'm not a pulmonologist. I know a lot of drugs. That one I hadn't known. So this is a corticosteroid. So it's an inhaled steroid and what's called a long-acting beta adrenergic agonist, which is called the LABA, L-A-B-A. This is a very common combination of drugs. So there may be others that are even cheaper. This is a very common drug combination for like asthma and allergic asthma. So I bet that's why they gave it to you. So yeah,
it's approved by the VA. The Wixella, my costs are nominal, if anything at all.
Yeah.
I probably can get it for nothing. But the Brio was not on their list, so it wasn't one of their generic prescriptions. So the first time I had to pay out of pocket, and it was rather expensive.
No, I'm sorry to hear that. It's a combination inhaler, I believe. Fluticasone and salmeterol are the two, or salmeterol. Those are the two drugs found in that. So sometimes we can give them separately, but it's a little bit of a problem to have to do all of that. So they've combined them in this way. So there's several products that have that combination. So I'm glad that you're able to find that. Thank you for letting us know.
Thank you for responding to me.
Absolutely. I think
Augie.
Oh, hey, Augie.
Good morning.
Good morning. Hi, Dr. Lisa. How are you?
Good. I spent a little time meeting your son at the meeting, and he was your advocate, and so much like you. I was talking to you. Great.
I thought you were going to say clone.
Yeah, he definitely is your mini me, maybe your mini me.
That's right. That's right. That's right.
Pleasure.
I've got two questions for you. One is, in your experience, I have come across at least two, possibly three other people with IBM who have experienced partial paralysis of their diaphragm. So in regards to potential lung issues and in conjunction with IBM, Have you come across that in your experience? The other question is in regards to dysphagia, possible one of the treatments available for dysphagia is a cricopharyngeal myotomy.
Yes.
Could you just touch on the pros and cons that go along with that procedure?
So well, let me just talk about the first. I haven't personally seen diaphragmatic paralysis, although the diaphragm is involved in myositis across all subsets of this, but that may also be a contributor of what people are describing here. So partial paralysis. I'll take it to heart, think about it and see, and actually ask in a room of all of us who have seen enough patients to see if others have reported that. So thanks for bringing that to my attention. Also, I must say that I'm not sure that I can really speak very well to a cricopharyngeal myotomy. I know the procedure, it cuts the muscle, right? It's just cutting the muscle at that area of which the cricopharynx or the upper pharynx. Beyond pros and cons, Augie, I'd be concerned that I don't have the expertise to really walk the audience through all of that. That would probably be best answered by a speech therapist that has much more experience, or the surgeon that does the procedure. I assume always what you lose in a myotomy, where the integrity of the muscle is compromised and you're trying to fix one problem by creating another. So I think that's always a give and take, but I would assume that there are, maybe relieving of choking in some ways, and maybe there's pulling of food in others. Again, I'm conjecturing. I really don't know. And I haven't seen enough people that get that procedure that I personally have experienced seeing the pros and cons of it. I would think that I'm sorry to say that I'm probably not the expert to discuss that with any finesse to be able to give you concrete answers beyond the hypothetical ones that I would assume happen when you cut the muscle.
Okay, well, thank you very much for that. I appreciate it. You've given us quite a few concrete answers today already, so you're doing very well.
Yeah, that one I'll work on. I'm gonna have to do some homework. You all might be I always have homework after I talk to these groups. You teach me more than I teach you, I think. So nice to see you on the screen. It's really nice to see you.
Okay, good to see you too. Thank you. And thank you for being on the MAB.
Oh, my pleasure. It's really an honor to be there. Thank you.
Troy Hicks, good morning. Go ahead and unmute yourself, Troy. There we go. Good morning to you.
How you doing? Hi, Dr. Lisos. My question's around the ABC 008 clinical trial. I'm participating in it. And so during the annual patient conference, I had asked a question about the KLRG1 protein. And so the question was, does every T cell have this protein in it? And from my understanding, this drug goes after those crazy T cells with this in there to try to kill it before the KLRG1 gets expressed out. So, I'm trying to get an understanding does every T cell have this protein in it? And for some reason, some T cells are expressing that out?
Happy to try my best. And again, I'm not a T cell biologist. Maybe I'll also show you my lack of full, my background in immunology, where I haven't been at the bench or in an immunology lecture in 30 years. There are different types of T cells. We have helper Ts and killer Ts, or we call them cytotoxic T cells. From my understanding, and believe you, before ABC 008, I had never heard of KLRG1. It's not like this is well known at least to me as a rheumatologist. So KLRG1 is a marker for cytotoxic T cells, the killer cells. What we're trying to do is target only those cells that are the pathologic ones in IBM. The thought is that particular type of cell, that killer cell with that molecular marker, but it's not targeting what KLRG1 does. It's targeting the marker. So it's sort of saying in the immune system, I have helper cells, I have killer cells. Come find just the ones that are bad. That's a marker saying, come here. And so we have figured out, the people that have developed this drug, Steve Greenberg and Abcuro, have learned that they can create an antibody that specifically targets that molecular marker on that cytotoxic killer T cell and kills only that cell. Because you don't want to kill all the cells. You certainly don't want to take your helper cells down, because then you don't have T cells to fight infection. So it's always a give and take. When we know it's probably a T cell driven process, when you wipe out the immune system, then you're really at risk, certainly during a season like this, viral season and others. So it's thought to be a narrow therapeutic target, targeting the marker on those cells thought to be causing the problem in IBM. Does that make any more sense than what you've heard before?
So that's why I kept trying to get an answer to understand exactly how that is actually then. Plus, I guess the next one is how, when it gets into the muscle, that's where it's causing the damage.
That's right. You're trying to get it not to do that. So the goal is for it not to go from the bloodstream to your muscle to do the damage. So these things, you know, our immune system thinks it's helping. Autoimmunity occurs when your own immune system goes rogue. It doesn't mean to attack you. It thinks it's doing something productive. We need cytotoxic T cells to kill other things, just that it shouldn't be killing you. So that is the goal, is to try to just get just that subset of those T cells that are killer Ts, that are specifically honing in from your bloodstream to your muscle, and have it not do that. At least that's my rudimentary sort of global understanding of the way that this is touted to work. Sure.
From a little bit of a more basic approach here, if I could ask for all of us here, I understand the basics of the T cells, but could you describe a little bit more about what is a T cell? I know it's part of the immune system. It comes from the bone marrow, is my understanding. And what is the function of the T cell?
Yeah. So we have. Oh, excuse me, one second. So you have T cell. These are different types of white blood cells, right? So they don't always stay in the bone marrow. They actually come out to help us. The easiest way to say it is that, what can I say that's like not, I don't know, this is a group that probably knows more than I do at some place. So this is part of your adaptive immune response, right? You have a cytotoxic T cell, which I've talked about, which destroys, and a helper T cell that helps to signal other immune cells and then talk to the B cells. B cells are your other type of lymphocyte, which makes antibodies. It does other things, but the function is to be your earliest adaptive defense against pathogens. It's supposed to be a good thing. It's supposed to kill pathogens that invade you. And then B cells are supposed to make the antibodies that help that. So T's and B's cross-talk in the immune system, where the B cells make the antibody and the T cells help present those foreign proteins, foreign substances to the B cells to do that. That's essentially probably the best way to do that without having a full biology lesson.
Yeah, well, it's these are the esoteric terms that we need to, make sure that we understand the basics. It comes
from the name T. The T part of the T cell comes from the thymus, which is a gland that we think you educate your immune system through certain organs, your spleen, your thymus. People don't even know exactly what the thymus does, I think, but that's where your blood cells get educated. And what does education mean? It goes into those organs and it says, this is a cell that knows self from non-self. So there's something called tolerance, where you have these blood cells that tolerate you. You know the difference. You're like, I am not a foreign invader. I am my own muscle cell. And here's where I can't tell you what happens. Those T cells go rogue, forget that it is not you, that you are not, you appear, your muscles, for whatever reason, and not other organs, I don't know how it targets just the muscle, but the muscle then appears foreign, and it thinks it's part of the adaptive response, helping you. And instead it's destroying your own muscle tissue.
Does the T cell play a role in the aggregation of the TDP-43 in the cytoplasm?
I don't know. Probably yes. Again, I'm going to be clear that I don't spend a whole lot of time at the bench. I do know that TDP, and Tom Lloyd has done a lot of work in TDP, of course. Whether it's definitively doing this, I don't know. I would just, maybe somebody knows. I don't even know I don't think anybody knows for sure. I believe it's been postulated. So I'm not sure. exactly what's happening. We don't even really know 100% why these aggregates occur. For a while, it was said that this is all beta amyloid aggregates. Then if you actually look back, maybe not. So maybe it's not as easy to say that those proteins are not just beta amyloid at all. So I don't know that we really know. And I think I'd probably be remiss to say that I have the expertise to tell you what's going on.
So the question marks on that TDP-43 are still out there in multitudes.
Certainly for me, probably Dr. Lloyd could give you a much more sophisticated answer of his hypotheses. Because I'm not a bench scientist, I don't really know the specificities of what they really think is going on. But I think even the bench scientists, it's all postulated. This is all hypothesis. Nobody really knows. They're taking educated guesses based on what they think happened.
Thank you.
Sure.
Kevin, good morning. If you could unmute yourself, there we go. How are you?
Yes, good morning. Once again, Dr. Stein, I wanted to provide some feedback into one of the subjects that was just brought up regarding the myopathy.
Sure.
Not myopathy, the throat procedure, which is the myotomy. The myotomy. I had a myotomy done at Johns Hopkins in 2022. Dr. Shuman Dar was my doctor. Now, granted, there is risks associated with doing the myotomy, but in my individual case, it has been a game changer. Now, that's been about 2 years since I've had that done. And what's interesting is I was having a really hard time eating and drinking. And I'm a relatively young guy. I mean, I'm only 61 now, and I've got a long life to live. So when they did it, there was a recovery period of about maybe 4 months. There was scar tissue. There was like a scratchy sensation. And at first I thought it was unsuccessful. But after the healing took place, it turned out to be a game changer, and it is a game changer today. When you couple the myotomy with the speech therapy exercises that I've been prescribed, the first one being there's a special device that I have to blow into. There's a couple of these other exercises where I got to bite my tongue and swallow my spit, which is kind of gross, but it's effective. And then there's the forceful swallow, which was a very, very effective speech therapy exercise. So a combination of all of those different factors has put me in a better spot today than I was in 2021, 2022. So I wanted to share that for the group. Over.
Okay, Kevin, thank you very much. Let me interject something here, and I just wanted to do this as a precautionary note, is that we're talking about a lot about therapeutics, treatments, and I encourage you to present any questions you may have on any of the topics that Dr. Lisa has shared with us. Check with your own primary care physician or your rheumatologist or your neurologist. Let them expand on that information rather than jumping off, because we've covered a lot of territory, and what works for one person may not necessarily work for the other. So just sort of a word of caution. Dick Mason, good to see you.
Morning, Jim. Can you hear me?
We can hear you just fine, thank you.
Morning, doctor. Thank you for joining us. Two muscle systems that are my most day-to-day problems are my legs, which are filled with blood, I guess it's called edema, and my bowel muscles. And so I know that all of these are affected by my living in a wheelchair. Do you know if IBM is affecting either of these muscle systems? Thank you.
Yeah, I think so. You had said your bowel muscles, and what was the first one?
I have a very difficult time moving my bowels.
And then I think you said two things. So it was affecting your bowels, but you had asked about the other one too as well. What was
the leg muscles?
Oh, your legs themselves? Oh, you're saying that the edema that you're having, is that correct? That's what you're wondering
Yes,
about?
I have edema.
Got you. Yeah, so I think the edema is probably dependent, which is just, it pulls because the valves, this happens not in a wheelchair, but when you have your legs dependent, meaning that they're dangling down and they're not up, the valves that are normally returning the blood supply back toward the heart, they become incompetent over time. They just become loose. And so you can't, that's why blood pools in the legs. That's very common. You often get what's called stasis dermatitis, where you get these dark coloration around your shins because the blood flow just doesn't move where it's supposed to. So it pools and becomes darker on the skin. That's a function of almost certainly having your legs down most of the time, I would guess, not IBM itself. The second one about your bowels, the one about your bowels, I have to say, like, it's true. Dr. Marilee Needham and others in Australia, I believe they had an abstract about this on one of our recent global conferences on myositis. And patients have been telling us about pelvic floor issues. Women talk about it, men talk about it. So I do actually think in some people, it really does become a problem. Again, I don't know if disentangling it just from being chair bound, to be stuck in the wheelchair full time, that also people who are in wheelchairs for other reasons also report this, exactly as you've said. But there does seem to be, even outside of being confined to a wheelchair full time, some bowel related issues.
Thanks very much.
You're very welcome. I think they're being looked at a little closer because I think we really did not concentrate on them so much. We don't have a lot of expertise in this as rheumatologists and neurologists, but I do think that we'll be hearing more about that. You're welcome.
Dick Burley.
Good morning, doctor, and thank you. Hi, Jim.
You're welcome.
Dick, how are you? How are things in Idaho?
Great. Still sun shining and starting to cool off. Doctor, my question to you is, and this really came up, you mentioned earlier about biopsies. Is there a national or international database of IBM biopsies? And then as a follow-on to that, what can we as IBM patients do for the medical community to provide the information that you need? If there was a national database of everybody with IBM, would that be of benefit to you?
Great question. I think right now what we do is that those of us who are part of large centers pool our data together. So we pool biopsy data, we pool clinical data. We're trying to all work together to do that. I mean, it's wonderful to practice in a nationalized healthcare system. That's why Sweden and Norway and places that have national healthcare can do so much better work when it comes to standardizing data. Part of the problem with asking patients to participate and give data, it really has to be individually vetted by physicians because patients get told they have something that they don't. While most of the time the inclusion body myositis diagnosis is certainly correct, every once in a while it's a genetic myopathy or something else, and we wouldn't want it to be. We'd want the data set to be as pure as possible. So I think that's part of it. But yes, I do think that we need to come to a system in some way where patients and physicians work together to do this in a more cohesive manner rather than piecemeal. Part of it, honestly, is just a matter of time and who will vet this. And, those are the kind of things to talk about it as a community to bring together. And if we did have a nationalized pool or resource, then everybody could utilize those resources to do research together as teams. I think it's something to think about. It's not easy. And to actualize it takes a whole lot of funding. It is just hard. If you just allow and just say everybody give their data, it has to be cleaned. It's not something where you can just give your opinion or send things. If somebody sends a muscle biopsy, someone else has to read it and catalog it and properly code it to be able to be usable in any fashion. So what you bring up, I think, is important. We can talk about what that might look like, but I think ultimately it requires funding and resources to do it properly. You really need a village, and you need really a village of full-time people curating that resource to make sure that it's properly done.
Gotcha. Thank you very much.
Thank you. Thanks for bringing up that option. Maybe this is a discussion to take offline.
One of the, as another follow-up on that same line of thought here, do research medical centers such as Johns Hopkins and others, is there an active sharing of research data between these institutions?
Active in the sense that it's like exists all the time. No, there is a full, so Dr. Meckley was mentioned. I know you mentioned that one of our folks on that line had mentioned that was your physician. So Dr. Meckley is heading a really global effort to help standardize data through a common data model. The goal will be that we all share data rather than samples and the way it's done now. in medicine, because of ethics laws, which are appropriate, we have to have a data use agreement, a material transfer agreement. So all of these agreements take forever to come through an Office of Research Administration. And then my Office of Research Administration needs to talk to Sweden's Office of Research Administration. So suffice it to say, it's not easy to do. It's protecting your data and your samples, in the right way. So the future is for everybody to code and collect data in the same way, and then you share the code. You don't share the samples. And that should make it much more efficient to do high-level data across multiple centers and not having to, reinvent the wheel each time.
Would you please invite the Veterans Administration to participate in that?
That would be a very interesting way to do that. Yeah.
Yeah. I shared with you our struggles of when we began here, of the frustrations that we veterans face, and which was one of the reasons I asked that question, is if there was some reference that we could direct the VA to, but we'll proceed along that path. But I just wanted to find out if there was some kind of a central research going on by one of our advocates who's been incredibly helpful is Todd Cohen out of University of North Carolina.
Yes.
And he has been a tremendous aid to us. He's like Dr. Tom Lloyd. He has written some very powerful advocacy letters, and we would like to get that information that is subscribed to by Tom Lloyd and Todd Cohen to get doctors, more of our family doctors, our primary care physicians, our neurologists, our own rheumatologists, to be able to reference those and get a better understanding of the complexities and the broader scope of inclusion body myositis. And so hopefully that'll all come to fruition one day. Teresa, good morning again.
Good morning again. Doctor, I have a question that may or may not be relevant, but we are facing a partial sternotomy to remove an anterior mediastinal mass. And when you mentioned that the T cells are produced by the thymus, I immediately wondered if the biopsy that the doctors will do after this mass is removed could possibly be relevant at all to my husband's IBM diagnosis. Because the surgeon who's handling this issue is obviously not, he's a thoracic surgeon, not an IBM expert. So I just wondered if any IBMers have presented with this type of mass under the sternum.
No, not that I've ever heard of or know of. I would say one thing to know is just to be, for that, I would definitely get a biopsy, take a look. And if you find something unusual, certainly bring it to your doctor's attention. I would be careful in the type of anesthesia that you have for that procedure. So just ask them to minimize or don't use paralytic anesthetics. It's hard to come off a ventilator. It's difficult to recover from the anesthesia from those procedures. So in general, I try to recommend that patients that are undergoing elective surgery not to utilize paralytic anesthetics. They use them less and less now, I believe, but it's important.
Okay, myasthenia has been ruled out, but you still would say don't use the paralytic.
It's because of the IBM, not myasthenia. It's because the muscle disease, just in general, my myositis patients that undergo therapeutic procedures that are elective, we try to reduce the amount of paralytics that are done. If you have to go into a ventilator and to be paralyzed to do that, we try to minimize or use less potent paralytics. Just mention that to the team and the anesthesiologist.
Thank you so much, doctor.
You're welcome.
Roland, you've had your hand up there. Thank you for your patience. Good morning to you.
Okay, thank you. I mean, going back to that reference to the mucus and everything concerning IBM, but I've also started to have, it's been in operation for quite a while now, is I get a body itch. I get itching on my back, throughout my arms, and I'm wondering if that's related possibly to the IBM, because I have found, I have tried numerous products to try to eliminate the itching. It keeps me up at night. It hurts during the day. and I've tried numerous ones. I keep it under control to some extent, but it never goes away. I have itching practically 24 hours a day, and most of the time it keeps me awake during the night. So I'm just wondering if the IBM is instrumental in creating this itching problem.
No, not that I've ever heard of. How long have you had it?
The itching started about maybe a month to 2 months ago.
So I would say that like itch like this that comes out of nowhere, it's sometimes what we call paraneoplastic. It actually can be part of a syndrome that related to cancer. I would just definitely get a very careful workup. That kind of itch that is that recalcitrant, that doesn't look like it's just dry skin, that's usually that's a signal for something else. So I would just make sure your internist was well aware of that, and try to investigate that. It's not part of IBM as far as I've ever known.
Okay, well, I had an idea. Maybe it was like a systemic type thing, but
it is, but it might be coming from something else entirely. I would just be really careful to make sure that you get an adequate malignancy workup. That's what I would recommend if you saw me.
Sometimes it drives me absolutely cuckoo. I mean,
no, itch is horrible. It's horrible. It's really terrible. I know. My patients with dermatomyositis, which is not what you're describing, have a lot of itch, and it can be completely debilitating. I think you tell someone you're itchy and they underestimate how absolutely life-changing it can be when it's this bad. This kind of itch like this, though, this is usually indicative of something else. It is a systemic issue sometimes. So I would mention to your internist that you were on a webinar and that the doctor mentioned that you should be carefully screened for malignancy.
I appreciate that very much. Thank you.
Good luck to you. Yeah, you're welcome.
Terry Baker, unmute yourself, my friend, there so we can hear you. And there we go.
Quick comments. What was that, Jim?
I said, and there we go. Good morning.
Good morning. Couple of quick comments. Several people mentioned the mucus buildup. Some of that could be because we're debilitated. We're not moving around like we're supposed to. One of the normal processes for moving the mucus is when you get up, move around, the deep breathing.
Correct.
And you're not using your accessory muscles as much. So the mucus doesn't move as well. And if you've been a smoker, you probably damaged the cilia, which are those little cells in the large bronchus that move the mucus up. And one thing you can do is just work on deep breathing and moving around and trying to do that.
That's that both of those are 100% true. It's a wonderful reminder that that's true physiologically. Exactly, that you're just not able to, to do that as you usually would do, for sure. Thanks for bringing that up. That's true.
I'm a retired respiratory therapist. That's what I do.
I was going to say, you sound like somebody who knows what you're talking about. Well, there you go. Yeah, you're not wrong. You're not wrong. It's 100%. People, who are hospitalized with the same idea. Just not
yeah, Terry's here quite often, and every time he comes on, he sends me a bill for a copay.
They can't hire you. We don't hire you.
He's not paying though. He doesn't pay.
I'd rather owe you than pay you.
That's all right. Lunch will work.
Do we have any other questions for Dr. Lisa Christopher-Stine? She has been tremendous in her sharing of her time and her talents and her expertise, and we will remain forever grateful for your helping us out here. This has been extraordinarily beneficial and quite informative.
Well, thank you.
I have one other question about the aggregation of the protein.
Oh,
and
no.
That is that just this is an easy one.
I don't know. The answer is I don't know. All right.
It's basically what came first, the chicken or the egg?
That's not easy.
Do we know do the T cells show up before the TDP-43 aggregation or after?
I don't think that is easy. I don't know. I mean, I know they're there at the same time, so I don't know exactly which happened when.
Yeah, I didn't know if one forced the other or vice versa. Which one came first, but it was just a question that I had, and it's just I think that's one of those question marks that just remain within the halls of science.
Yeah, I mean, and again, like I say, just because I don't know doesn't mean that somebody doesn't know that, but I don't know that we know that. I mean, certainly we know that both are present, whether one drives the other or whether they're intricately, definitely related. If that's the case, I don't know that I can speak to it. I don't know. You asked me hard questions. I don't know about that one. I'm not sure.
Okay. Well, thank you.
No
I won't
worries.
ask any more of those. I've shared, these guys will all tell you that over the years, I have, with our interactions with the VA and Inclusion Body Myositis, the medical side, the research side, the veteran side, I've always referred to this endeavor as a million-piece jigsaw puzzle. And
Really?
and we're just, we're just now trying to find the pieces. And
For sure.
yeah. Suds.
Brian O'Connell had his hand up earlier. And Brian, did you get your questions answered? Brian and his wife, Brian O'Connell?
Thanks, Studs. I did mostly. I just wanted to make sure I fully understood the doctor's perspective on IVIG and that it might be useful for 2 months or less. Could I just get an overview for 2 seconds of that,
Yeah,
Doctor?
no. So what I was saying is if you have the rare version that we think might be amenable to therapy, which is rare, I think that IVIG does not work in garden variety traditional IBM. I definitely think it does not work. But there are certain people that have what's called PM Mito, where it's like a little crossover between polymyositis-like features. There's a lot of mitochondrial damage that's very specific. The pathologist will tell me this looks like PM Mito. In those people, a 2-month trial is what I do. If it's working, I continue it, but I just don't go continuing it forever because people get stuck on the therapy and they don't need it and it's expensive and it's a blood product. So what I was trying to say is if you are in that rare subset that looking at the pathology a little closer, it looks like you might have that rare subset of what might be pre-IBM, might be a type of IBM, might be different than IBM. Those people, I usually just put them on 2 months of IVIG to see how they've responded. And if I don't see a signal, I stop it because even sometimes they don't respond. That's what I was trying to say. So thanks for letting me know.
Okay. I just finished my first week of infusion and I don't feel worse. So I'm cautiously optimistic. And that's the generality of what I was hearing from my neurological specialist. So,
yeah.
Okay.
Good.
Thank you
Good
very
luck to
much.
you. Yeah.
Thanks.
Seth Goodman had his hand up too. Seth, did you get your questions answered? Seth?
Yeah, no, I did. Yeah, I got my question answered. Thank you.
Okay.
That's it for me.
Terry, did you, I'm sorry, Suds, did you have anything additional to
No,
add?
I'm just going to lower my hand, but thank you, Dr. Christopher, for everything that you said today.
You're welcome. You're welcome. I went one in the chat. I mean, before I pop off, I'll run. Somebody did ask, I believe, maybe Londa Ross said, a doctor told them that he thought IBM was a subvariant of ALS. I don't think that's true. I think they're mimics of each other. As you know, has been talked about, this protein TDP43 is present in both. They look a lot alike initially, for sure. And people are often relieved to find out they have IBM and not ALS. So they can look a lot clinically similar. There's definitely some similarities pathologically when we look under the microscope and sort of pathogenically. But it's not, we don't think it's a subset. We think it's a different disease, but there are parallels. And that's why this discussion came up, because there have been parallels that ALS is much more common in service people, in the veterans. So maybe it's true that IBM is the same. And that's where Mr. Cressman and I started speaking initially about this idea that maybe there's this parallel there, but one is not a subset of the other, as far as I understand, and I don't think we think that scientifically right now.
And forgive me, but I just saw your message up there, Dr. Lisa.
No worries.
Forgive me for carrying on here. But you have shared a great amount of your time and your talents, and again, we are forever grateful. You just texted up here that you need to contact your parents who are in Florida after the hurricane. I hope all is well.
Oh no, yeah, they're here. They're here. I'm meeting with them, but I misunderstood, I think, the time. I'm like, oh, I just wanted to make sure. I didn't know how long the meeting went. I'm happy to participate, but I have to go find them.
You have been very gracious with your time, and we will remain forever grateful for your help here. So thank you. And our time is we have reached our time frame as well, and so we do have to conclude here. And again, our very sincere thanks for your help. I'm going to stop the recording here.
All right.
And if I can find out, where's my 12-year-old? And I will take care of that. But let's see here. There we go. Stop recording. Again, many thanks. We hope to see you soon. And if on a final note, if you would be so gracious as to perhaps text me or send me an email about the connection to the other doctor that you referenced about the VA.
I will do that. Yeah, absolutely.
That would be great. We can pursue that.
I
So to
will.
all of you, thank you. Be safe, be well. God bless you all, and thank you so much.
Nice seeing you all. Take care.
Thank you.
Thank you.
Thank
You're
you.
very welcome. Bye-bye.